Today's focus is to celebrate the impressive work you and your colleagues have undertaken to improve the quality of care in LHSC's emergency departments. It is important that as care providers, we come together to share our successes and collaborate on finding new and innovative ways to improve patient care, services, and safety. This approach is critical as we enter an era of unprecedented transformation in the healthcare system. Ontario's aging population and fiscal challenges have created the need to change the way we deliver healthcare. And as such, we are seeing system changes occurring at a rate that I have never seen in the past. As healthcare leaders with a legacy of innovation, I strongly believe that London Health Sciences Centre is ideally suited to help lead this change, and the ED Systems Transformation Project is helping to spearhead this approach. I think we all recognize that the past few weeks, if not months, have been extremely difficult for the emergency departments at London Health Sciences Centre. We have received media and public scrutiny regarding ED wait times and quality of care. I know that we are all frustrated when we cannot move patients in a timely fashion. Many legitimate concerns have been raised by staff, physicians, patients, and their families. We also know that our community counts on us to provide high-quality care, and I'm excited by the projects and initiatives that are underway, not only to transform the emergency department, but tackle the issue of flow in the hospital as a whole. To accomplish this, we cannot operate in isolation. Just as today's session is about sharing our learnings, ideas, and best practices, true system transformation means we must look at change well beyond our acute care walls. LHSC is actively engaged in developing strong partnerships across the region with the aim of creating innovative solutions across the continuum of care. The emergency department systems transformation is an inspiring example of what can happen when grassroots staff-led projects are initiated. I'm confident that your work will make a difference, resulting in an ED experience that is easier, faster, and better for patients and staff. In closing, I want to thank the ED staff and physicians for embracing this opportunity with enthusiasm and commitment. I would also like to thank Larry for being here today to help ensure the patient is at the center of everything we do. Your continued perseverance and dedication to these challenging times and your over and above efforts on the ED System Transformation Project speak volumes about your commitment for your patients. I believe we can accomplish great things together. Your ideas and innovations will ultimately improve the patient experience at LHSC, and I think across Ontario and indeed across Canada. Thank you, and I hope you have a wonderful session. I'm looking forward to seeing it, and I'm looking forward to seeing where Gary lands up in the simulation.
It is my absolute great pleasure to be here today and to celebrate with each and every one of you. So my message is going to be short, but one that I have to say is, as a leader, one of the most rewarding things that you can ever experience in your career as a leader is to see frontline people and grassroots people come up with the energy and the engagement and the excitement that you did to make a significant difference for our patients. So I'm so very proud of everything that you've done and want to congratulate each and every one of you. It takes true leadership to make a difference, and you're doing it. And what's most amazing to me, it's all about the patients, and that each and every one of you have dedicated your time and efforts and energy to really focus on what's right for our patients. So thank you. And thanks to each and every one of you for coming today. This is one of the most exciting projects that I've ever been involved with. I actually was here at a simulation before, and I took a picture of it on my camera, and all you see is a blur. And I saved that picture because I thought that's the difference that we're going to make with our patients. So congratulations again, and I want to thank the leadership, Mohammad, David, Carol, Adam, Carol, for all the work, but most importantly, our team. So thank you very much and congratulations.
Before we get into the meat of the presentation and the simulation, we're going to take you through a few slides that will help orient you to what we're doing and what this emergency department system transformation is all about. So a bit of an agenda on the screen. We're going to start by giving you a very brief history of the emergency department system transformation, or how we ended up where we are today. We are then going to describe our current state, what we think should be our future state, or our interim state, and eventually our ideal state of what emergency care should look like in the City of London. After that, I will introduce a simulation of K2. K2 stands for Kaizen 2, or one of our incremental improvement projects, which will be simulated with the equipment that you see in front of you. You'll hear a lot more about that over the next 40 minutes to an hour or so. After that, there'll be the actual simulation, and then time, about 20 minutes for a question and answer period. And after that, we'll have lunch and lots more time for question and answer with individuals. So how did we end up here? It's no secret, even from Murray's talk, that people are waiting a long time to be seen in the emergency department. When people wait a long time, the patients are frustrated, the nurses are frustrated, the doctors are frustrated, the people that clean the floor are frustrated, because it's not a nice environment to work in. I chose emergency medicine as a career when I was a second-year medical student. I was following one of my colleagues, Dr. Mike Llewellyn, who's in the audience with the EMS folks back there, and he was just starting his career after residency. I was only an observer. I wasn't really adding any value to the patients, that's for sure. Maybe I added a little bit of value to Dr. Mike Llewellyn because I was inspiring him in some way. I know the medical students inspire me today. But for the most part, I was not a value-added piece of the system. However, I felt embraced by the team, and that welcomed me to the emergency medicine community. But more importantly, I knew that I wanted to be a part of the social safety net that our emergency departments provide, or at least should provide, for the City of London and the County of Middlesex. Over the past 10 years, probably a couple more than that now, I've watched as our emergency department team and providers have been beaten up with long wait times, bed block, all of these other issues, high staff turnover. The environment has dwindled, to say the least. But eventually, it became time to do something about that. I won't go through the details, but we landed on a project charter in November of 2013, and actually just launched this project we're talking about today 4 months ago. This project involves transferring the Toyota production system knowledge to the front lines and involving them.
I wanted to say thank you for everyone who did not believe in us, and every person who was skeptical about what we do, because that was the root cause of our success today, and that is the very right opportunity for us to say, you know what, we are a bunch of believers and we are going to do that. What you're going to see today is a pure love story. It has nothing to do with expertise. It is a culture based on love. Love to do the right thing. You will see people sitting around you, spouses of people over here. You will see things generated by kids doing things to be part of us today, but they are not with us. This picture means a lot. In the heart of the picture, you will find a small little girl in the lap of her mom. That's Dr. Church, Caroline Church. You can identify yourself. She was breastfeeding when she used to come and attend these sessions. And that is itself says something. The only motivation for her to do that is her passion to make a difference and see that we want to make things better. 1, for the patient, 2, for us as providers, 3, for the organization, 4, for the community in London, 5, for Ontario, and 6, for Canada, and 7, to the world. And our commitment will not settle just by fixing the emergency department. Our commitment is by becoming the showcase of every person in the world to say, this is where this came from. You might think that we dream, but this is what's good about us. You can either dream and be part of us, or you can just watch. Thank you very much.
As Mohammad said, this is a grassroots-driven project. The motivation, the drivers, and the project leads all come from the ED team. They've done an amazing job. Collectively, they have come up with homegrown solutions to make the care for our patients in the emergency department easier, faster, and better. Who knows better than the frontline staff what's working and what's not? So they have worked tremendously hard to come up with really good solutions. The goal of this is really to get rid of the waste, so make incremental improvements by eliminating the waste. And you can see here the waste we refer to as MUDA. This is non-value add. A lot of the work that we do has absolutely no value to the providers or the patients. So as they're developing the processes and systems, when they're looking how to revise their care, they're really conscious as they come up with the solutions in terms of what is the value, what's waste, and how do we eliminate it.
So you'll see along the wall the current steps in our current processes in the emergency department from step 1 to I think it's step 129. We've sat down as providers and looked at every step in that process to decide what adds value to the patient, what adds value to the provider. And because we're a teaching institution and we want to train those individuals that will look after us when we retire, we've thought about our learners. And we've identified our waste, or our MUDA, in red. So if you look along that wall, everything in red is waste.
This is our MUDA map. On the top we have our patient families, which in a nutshell is groups of similar patients. Down the left we have the various steps. I know you can't read patient families or the steps, but I'm sure what stands out to you is the red and the yellow. The yellow is value for the patient and the provider. Red is the MUDA. This is a tool we use to create this value stream and to identify the MUDA that we are going, or is currently being removed. Along the way, we've had to adopt some new language. Our group currently speaks in terms of current state, which is the ED as it exists today, the future state, which is the ED that we are going to demonstrate in a few minutes, and ultimately the ideal state. Adam, Mohammad, and Carol spoke about this project being about culture, and one of the aspects of this culture change is continuous improvement. So our future state, yes, is a massive improvement, but that's not the end. The team will be continually making small incremental improvements leading towards the ideal state. Our value stream has been mapped, and we have initiated 2 Kaizens, and I think Carol's going to speak a little bit about those now. No? But before we go, for a little drama, here's our MUDA, and this is what we think of it.
Okay, so Kaizen. What does the word Kaizen mean? It means change for the good. It's a Japanese word. It really focuses on making little incremental changes to get to your ideal state. So you break things apart, put them back together, and make them better. And that's what the staff are doing right now. We have 2 Kaizen projects that are currently underway. Kaizen 1 actually came out of some of the principles of the Toyota production system, which really has to do about eliminating waste. This project focuses on eliminating the waste that's associated with clutter and motion. So what the staff came up with, there was a recognition within the department that we had referral forms all over the entire emergency department. And people were running everywhere to find them, plus, as nurses and doctors always are, they have little stacks of everything everywhere. So what the group did, the project team got together with the help of one of the webmasters and actually cataloged and put all of the forms that we have on one web-based system that is easily accessible for all of the physicians and staff to be able to access. This is the first step in getting to our ideal state, which is actually going to be complete electronic referral process. So they've done a tremendous amount of work on this, and it's up and running now.
Can I just ask all those involved in K1 to step forward from this part of our EDST team, but also like Dr. Theakston was involved, and I see some other members of the EDST team who don't have t-shirts but are in the audience today. So Carl, can you stand up? And anyone who worked on K1, come forward. I just want to emphasize that something that when you describe it may seem small is actually a very difficult improvement to make. Changing practice, changing what doctors and nurses are used to doing every day of their lives for 5 years or 20 years or 40 years in some cases. So this team worked very hard, very quickly, in less than 2 months essentially, to eliminate 53 plus referral forms in our department.
The second Kaizen event that we're working on is the one that we're going to demonstrate for you today, and that's the development of the production teams at the front end. These are only 2 that are operational right now. The group themselves have identified about a dozen more, and this group, the emergency team staff, will be developing and implementing those as we continue on our journey to transform the care in the emergency department.
Thank you, Carol. I want to just direct your attention briefly back to the value stream with the waste removed. There's less overlap, the value stream is shorter, so the patient's journey will be shorter and their experience will be easier, faster, and better. To highlight this, as we move into our K2 description, I wanted to go over what our current front end looks like. I'm using the term front end or front bubble to describe essentially how a patient is received either when they walk in or come in a wheelchair or by ambulance or police or however they end up coming to our doorstep for that social safety net or care that they were looking for. This is a CAD drawing or an architectural drawing of University Hospital Emergency Department. I've drawn a red line around the front end, the current front end. And I want to walk you through very quickly what that front end, so not the entire value stream, just getting to see a physician for the first time. So you walk in through this door here, which is often broken. You stand in front of that door and you look to figure out where you're supposed to go next. There's a couple signs, but they're small. You then walk to this plexiglass or bulletproof glass area to have the triage nurse who's sitting in this area here, who's already busy, probably talking to another patient, point to a chair for you to sit down in a very nice way. So that's talking to the triage nurse. Step 3, you sit down in a chair and wait for the triage nurse. Then when he or she's available, you come over to their desk and you get triage, vital signs done, or blood pressure, heart rate, your history taken. After that process, which takes anywhere from 5 to 18 minutes, you go back to a chair where you wait number 5 here before you go back to register with the comm clerk who puts your information in the computer and you get populated in the screen. After that, if you're having a complaint that may relate to your heart, you get an ECG done in this chair here. It's kind of in a back corner and no one can see you. And then you move out to the waiting room where you wait a couple hours most days. And then after a couple hours, we bring you back into this area where a reassessment nurse re-triages you to make sure that you haven't gotten sicker while you're in the waiting room as a safety measure. And then you go back to the waiting room for hopefully not another 2 hours. And then eventually you end up in one of these care spots, which for all the physicians and nurses in the audience know, if we're talking about this is C8 and C13, there's a couple stretchers and a couple chairs that are almost non-functional. That's our current state. This is where we are currently and this is where we want to get away from. I'm going to call on Mohammad and Blair Walker to describe this diagram.
Thank you, Adam. So, we all probably had heard or we have an experience about the current state. When we did all the mathematics and the numbers, and I must say that we went down deep to the, maybe I would exaggerate if I say seconds, but we do. While we are enabling people with the right knowledge to look at things differently and self-generate for their own selves a design that will work well based on the mathematics and the numbers that we've done. One of the things that kind of amazed me and astonished me, the knowledge that these folks gained in a very short time translated to real value. I want to introduce for you this good man over here, Blair. Blair is one of the nurses in the emergency room. I became friends with everybody. But he heard all of this and he called me at night, late night. And he said, could you take me through this? I want to do this. And I said, of course. And the only thing I've done with him is just mentoring. And I didn't know what he was doing. So he went online and he searched everything. And he found, because we're very budget-oriented people, he found this open source software. He never used it. And we spent a whole bunch of hours on Skype and calls and everything. And that's what he's done. I don't want to go through this myself. I'm going to give it to him. He's one of our emergency room nurses. You're talking about engagement, that's engagement. Empowerment, this is empowerment. This is exemplary. And Blair's wife is here. Where is she? You can stand up, please. That's Blair's wife. She's the one who prepared those cupcakes over there. Before you jump to those, and before you go to those cupcakes and eat them, please look at them and see how did this inspire everything in us. Blair, he is going to explain to you about this, please.
So when I came to Mohammad, I wanted to make a better front end that was more efficient. It was faster, better, and easier for the patient. So we as a team got together, brainstormed some ideas, and the ideas and the logic we used to produce what you see up in front of you. And so the logic behind what we've drawn here is that initially our current state is the patient has to penetrate into the heart of the department to actually access the healthcare team. It's very vertical, and it's not very efficient. So what we tried to do was to turn vertical on its side and make it horizontal and bring the healthcare team out to the patient. This maximizes patient interaction. It makes things efficient with the current resources we have.
We are going to describe at a high level our ideal state. Remember, we're talking about incremental improvement here. So we start in an area that we have the most control over and we think we can improve most readily, and we move to create the entire puzzle, the entire picture.
We dream.
We innovate.
We create.
We believe. We decided our value.
We know our purpose.
We aim. We achieve.
We accomplish.
Yesterday is behind us.
Today is ours.
We plan our future by understanding our current.
We painted our ideal state.
And we are moving. We save lives.
The best or none.
You will hear lots of terminologies that are very basic, like what is it that is making us different in what we're thinking? This is not really magic. And in my first introduction, when we did the launch, I said, you're going to find out that everything we do is basically instinctual. We're not bringing anything that is new science. So we're just thinking in all simplicity and basic logic. What we need is visibility. We need to see each other in the department, which we don't see now. Staff and providers and patients. Proximity to all our resources. While you're walking forever to get your ultrasound machine, now it's going to be right next to you. And we're using this method of basically an arm length, wherever you are, wherever you're doing. So the open concept is based on the visibility proximity. Now, as likely as this can be, this is done somewhere else. It is not, because we're measuring visibility into 65,000 pieces of data and proximity. We match them out, and then we have a ratio and index, and currently it is less than 15%. With our open concept, it's going to go up by 95%. How does that impact you? So, you will hear us saying about 30 minutes, 180 minutes, and 23 hours. The impact is that we want to eliminate 30% of our volume. These are patients that they take the shortest, least encounter time, but yet they wait the longest. That is where our mood is. We want to get rid of that, eliminate it, with the least provider time. Imagine that. So if you have 10 patients, and the encounter time is 15 minutes, in total it's 150 minutes, but these guys, they wait for 8 hours. So that's why you have waiting. And reduce admissions to decompress inpatient beds. This is in itself transformational. We're also taking command over our own self to decompress the hospitals by reducing admissions. Streamline encounter times. When you streamline encounter times, then you can control your outcomes. This is the basics of open concept in all simplicity. So we designed 3 bubbles: the front bubble, middle bubble, and the back end.
When patients come to the emergency department, what they value is rapid, timely access to their care providers and high quality care. And what the front bubble or front end is designed to do is to provide that. So it's designed as an area where people can directly enter the emergency department, and we've removed many of the redundancies or waste or muda in our current processes so that we can provide direct access to the nurse and the physician who are actually going to be looking after you when you come to the emergency department. And that access can be provided as soon as you walk in, as opposed to waiting for multiple steps. And by providing a front end where you directly see the physician and the nurse, we can actually project that with the appropriate systems in place like this, and with the appropriate space to see patients, we can see patients within 30 minutes of their arrival and have them looked after by their primary nurse and physician immediately, eliminating all of these steps that intervene in between and make us inefficient. And that's the concept of the front end.
I'm talking a little bit about the middle bubble, and what the middle bubble is about is there are patients who we begin the investigations or begin treatment in the front end who will require a longer length of stay but likely not be admitted. So these are patients who may need procedures, investigations, or therapies that can take up to 180 minutes, and they will be cared for in what we're referring to as the middle bubble, with production teams who are familiar with what is going on for the patient and what we anticipate to be their outcomes after their investigations and therapy. This is a Kaizen that is currently underway, and we're very much looking forward to any input and solving the problems that we currently have in order to make this more efficient and better for the patients and the providers.
The back bubble is a Kaizen that we haven't started working on yet, but what we're planning to do in the future. At the moment, it's an area in the department where patients that need longer than 180 minutes of care are being treated. In our current model, we have patients in those areas that can be there up to 3 days or longer waiting for admissions. And that's something that in the ideal state we want to get rid of as MUDA. We want to achieve a stay of 180 minutes to 23 hours. One way we're going to do this is by using multidisciplinary approaches involving all the teams in the hospital, and we'll use standardized clinical pathways and hopefully reduce some of the admissions that are currently happening that may not need admission. We look forward to involving the whole organization to achieve this ideal stage in the future.
So at the back of the room, or opposite me, we will have our patients ready to go. Those patients are not trained in our system. They have not seen this system before. They will be randomly given cases to present to that the providers have not seen before. As they come through or into the front entrance, you'll see 2 mock computers on the front desk with a meter of comm clerks. The comm clerk will quickly register them in the computer. They will then meet a sensei or sorter, who will usually be an experienced nurse in the department. And then they will be sorted to either resuscitative or non-resuscitative. So at that corner of the room, there's a recess room or trauma bay. We are not simulating the recess room or trauma bay today, so that will be imaginary. The production cell, or these 3 stretchers and chairs you see right in front of me, is our functional production cell today. Given the math that Mohammad and the team have done, we need 3 production cells at both emergency departments, each with 3 stretchers, in order for our model to work. Today we'll simulate 1 of those production cells, but we'll have enough patients for 3. We'll simulate our flow at a higher rate than we've ever seen in our departments. In order to do that, our sensei, our experienced nurse that will be basically in the center of the room, will be sorting patients to 2 imaginary production cells as well. You can imagine even getting the equipment here from the hospital wasn't an easy task, so it would be difficult to simulate all 3 production cells, nor could we find the space to do it in. So on either side of the room, we have Allison, one of our charge nurses from UH, and Tracy, one of our charge nurses from UH, who are manning our imaginary or non-functional production cells that patients will be sorted to. All our providers are wearing different colored shirts to indicate what type of provider they are. So our comm clerks are in pink and they have pink hats to indicate that. Our sensei is in green and she has a green hat. Another comm clerk within the production cell wearing pink. Dr. Shaw or Amit Shah in blue is the physician. Norm is an EDT or emergency department technologist. Orderly in the old world was wearing black. And then Mo or Maurice is wearing green as a charge nurse in the department. And Bonnie in white is a nurse within the production cell. So the production cell, as you now know, is being staffed with a communications clerk, an emergency department technologist, 2 nurses, and a physician. Okay, go. Okay, so I'm going to pause the simulation. You'll notice we've now received 2 patients at the comm desk or the customer service desk. The first patient, Larry, has been sorted by Mary to the active production cell. You'll also notice the team, or hopefully notice the team accessed our micro inventory. So Mohammad talked about everything being within arm's reach, and everything that you would need most of the time, or things you need at least 80% of the time, is in that micro inventory, so the providers can use it immediately. It's also blue on one side and green on the other, such that visibly you can indicate to the EDT or anyone who's going to be doing stocking that it needs to be restocked. Not when the bin is empty, but when the bin is going to be empty soon. So the supplies are always available to the provider when they need them. Go. Pause. Hopefully you can appreciate at this point how vital the role of the sensei is in sorting patients. She has indicators for each production cell that are either green, yellow, or red. Currently all the production cells are green and ready to accept patients. Beyond the indicators themselves, she can also see, because it's visible, what's going on in each of those cells, and knows what she's sent to each of them. So she knows the workload or how much work that production cell has ongoing currently. You may also notice that at the end of each bed, there's a smaller card, indicate whether the bed is dirty, occupied, or clean. So Audrey currently is cleaning the bed that the patient was just in, so it's red. Whereas the other 2 beds, the bed on this side is green, and the bed the first patient in is yellow. I also want you to note that the distance planned between each of these stations is purposeful. It's meant so that people don't have to slow down or stop or queue up in between each station. So based on our estimated patient arrival times, there should not be a queue forming because of the length of time each step takes and the length of time it takes someone to move from one spot to the next. Go. Pause. So about 30%, or actually less than 30% of our volume comes in by EMS, and the acuity of EMS patients, or how sick people are, tends to be a little bit higher, but they're not always resuscitative, obviously. We do get the heads up over the phone from EMS on most patients today. We're working with our Middlesex London EMS, as well as other EMS providers, to refine that system as part of K2. Part of how we receive patients, so that we can better communicate with the patients as they come in, because they've already done a history, they already know the vital signs, so the information that the sensei needs to sort them will be readily available before the patient even sets foot or stretcher through the door. Go. Pause. So what just happened there, was the comm clerk at the front indicated a code blue, indicated that a VSA came through the front door or someone that needed to be resuscitated. So the sensei will pull staff through a CAN van or indicator system from production cell into resuscitation room to supplement the staff that is already there. So we'll have 3 physicians at the front, 1 in each production cell. One of those physicians will be pulled to do the resuscitation, along with 1 of their nurses, but the production cell continues to have some staff in it. Go. Pause. So 2 things that I want to highlight right now. The production cells that are on the side are non-functional. Just to remind you, the reason the patients are basically sitting in chairs and not getting triaged and seen by the doctor is because we're not demonstrating those production cells. But imagine that those 2 cells are exactly the same as this. Same carts, same stretchers, same CAN band indicator in terms of colors. So they're essentially virtual or imaginary production cells. At Victoria Hospital is where all of the obstetrics is done in this city, or baby delivery. And this patient that is presented as plus 20 weeks pregnant would be directed immediately by the sensei up to the OB triage under our current process. Go. Stop. So we just witnessed a patient that most of us in the room probably know faint at the front desk. And obviously when someone goes down like that, we don't know if they're fainting or seizing or dead initially. But very quickly our team was able to assess whether or not she had a pulse, and our sensei determined that she felt this was a syncopal episode or a fainting episode, so the patient does not need to be in the resuscitation room and can go right to a production cell. Still sees a physician almost immediately. Dr. Shaw had his hand on her pulse, a radial pulse, and probably noted that she still had a strong pulse and likely had a reasonable blood pressure, and we could hook her up to our monitor and do as we normally would do. But she was still quickly seen, sorted, and put into a production cell. I missed one opportunity to note our first patient, when he came back from X-ray, was sitting in a chair behind the stretchers. In the real world, or once we have our facility changes done, the chairs will be visible to the care providing team so they know when the patient is back for reassessment. Not just one person, but the entire team knows, and they can either bring them back into a stretcher for reassessment, so that stretcher be occupied, or reassess them in a chair depending on the patient's need. Go. Pause. You'll notice a couple times, or hopefully you notice, that 2 patients arrive simultaneously. 2 patients arriving at the exact same time is not a rare event, but it doesn't happen all that often. Sometimes as many as 3 or 4 arrive at the same time. With 2 patients, the system we're modeling today could easily deal with that volume, arriving instantaneously. You'll notice that just because of conversation, how long it takes at the front end, whether it's 7 seconds or 30 seconds, depending on the type of patient, you'll end up with still the sensei only having 1 patient at a time and no queue. However, if 4 patients or 5 patients arrive at the same time, the sensei has the ability to pull staff from a production cell to the comm clerk desk or to the sensei desk to help deal with them in a more expeditious fashion and get them into the production cells as quickly as possible. Go. Stop. Thank you everybody for your involvement. I want to summarize what we've just done in 20 minutes. Julia, how many patients did you send in? So 22 patients in 20 minutes. If you look at the last 6 months stats, we've never received 22 patients in an hour. Obviously this is a simulation and there are other issues that are going to come up, but this system has redundancies built into it. How many people were seen in the production cell and discharged? So 3 were discharged. Mary, do you know how many you sent to the center production cell? I counted 10. So that's about what we would expect to do. We have 30% of patients that would be seen in this front-end production cell and discharged from the department in that 30-minute window. The other 70% will require further investigation and moving on into the front bubble. The important piece of information here, though, is that they've seen the providers immediately or almost immediately had decisions made on what their care and treatment plan should be over the next few hours in the emergency department.